So how do we categorize the pneumonia of the patient? Okay, so the pneumonia of the patient is categorized as mild, moderate, severe, and that is dependent upon the oxygen status. Okay, the oxygen status is compromised. Generally, oxygen saturation should be 88 to 90%, 92%. But on the ABG PF ratio, we have to find out PF ratio, PaO2 divided by FiO2 ratio. If the PF ratio is less than 300 and between 200 to 300, we call it as ARDS, mild ARDS. ARDS is a respiratory distress. Okay, it is the more severe form of a pneumonia where the patient is getting affected with the pneumonia and there is further progression of the lung infiltrates. Patient becomes more and more hypoxemic and there are bilateral opacities on the chest and there is no evidence of pleural effusion or any cardiogenic pulmonary edema. We call them as having ARDS, and especially if the PF ratio is less than 300 to 200, we call it as mild ARDS. If it is 100 to 200, we call it as moderate ARDS, and if it is less than 100, we call it as severe ARDS. So severe ARDS, moderate to severe ARDS are the patient who will need invasive intubation and mechanical ventilation, whereas mild ARDS can be managed with hypoflow oxygen device, or they can be managed with the BiPAP machine. And this is how the ventilator strategies, when the patient is on ventilator, the low tidal volume lung protective ventilation strategy should be employed, 6 to 8 ml per kg, and we should monitor the compliance of the lung with the plateau pressure and the driving pressure. Okay, these are the monitoring. We should monitor saturation, chest movement when the patient is on ventilator. We should also see whether there is any problem during intubation. If the patient is on ventilator, suddenly oxygen saturation is dropping, that gives you enough clue that the patient has either pneumothorax or collapse or bronchospasm and pulmonary edema, and it has to be addressed immediately. So management of ARDS is basically ventilator strategy, but some patients whose lung compliance is so poor, they have such a diseased lung, they may not be well managed with the usual ventilator settings, so they have to be given a prone position. Okay, when we are giving prone position, the intention here to improve is oxygenation. The posterior part of the lung is not contributing in oxygenation and ventilation, and these patients can be benefited by giving prone positioning. And those patients who are even not getting better off with the prone position, they can be given ECMO as a procedure. Some patients may also need lung transplantation. So that is all how we go about in managing ARDS patient. But when we are monitoring this patient, we should not overzealously give a lot of fluid. Low tidal volume should be used on ventilator, and we should have accurate assessment of the oxygen status of the patient. If it is mild to moderate or severe, and accordingly the oxygen devices can be used. We have seen patients with the COVID-19 infection getting affected with myocardial injury, myocardial infarction. So that also adds to the problem. If the patient develops myocardial injury or MI, the mortality rate is more than 50%. Versus those patients who don't have cardiac dysfunction, the mortality may be 5%. Most of the patients also develop acute kidney injury due to COVID-19 infection, which can be either 5%. But this is the late manifestations of acute kidney injury. This could be due to inadequate resuscitation or drug toxicity or hypotension, severe hypotension, or patients with high vasopressor agent where the blood supply to the kidney is compromised, and nephrotoxicity with the higher antibiotics, nephrotoxic agents, antifungal agents that are used that can cause acute kidney injury. But the treatment for acute kidney injury, good resuscitation, supportive care, and those patients who are not responding to the usual supportive care may need renal replacement therapy. So how do we assess hypotension? If the patient has warm skin or wide pulse pressure, this patient is definitely having septic shock or sepsis. But if the patient has narrow pulse pressure, his skin is cold, clammy, and the patient has narrow pulse pressure, this patient is hypovolemic. So we should be able to distinguish septic patients versus non-septic patient, hypovolemic versus non-hypovolemic patient. So if the patient has severe vasodilation, their lastly blood pressure is very low and they have wide pulse pressure, so these patients are septic, they should get good antibiotic cover, source control, and then they should also receive steroids for adrenal insufficiency and all. But if the patient has low pulse pressure, their skin is cold, clammy, they may either have low cardiac output because of the hypovolemic status or cardiogenic status, low ejection fraction like cardiomyopathy or arrhythmias or valvular pathologies, or obstructive pathology like pulmonary embolism or tension pneumothorax can also be a reason for their hypotension.